Comprehensive management of lymphedema with complete decongestive therapy. Lymphedema affects an estimated 1.5 million individuals in the United States annually, representing a 0.5% prevalence of chronic limb swelling. The condition arises from impaired lymphatic transport leading to protein-rich interstitial fluid accumulation, inflammation, and adipose tissue deposition. Diagnosis hinges on a combination of limb volume measurement, greater than or equal to 10% increase over contralateral limb, and imaging. Lymphoscintigraphy sensitivity is almost equal to 92%. The cornerstone of therapy is Complete Decongestive Therapy, CDT, a multidisciplinary regimen comprising manual lymphatic drainage, multilayer compression, therapeutic exercise, and meticulous skin care, which reduces limb volume by a mean is almost equal to 30% after 4 weeks. Key points. Note: lymphedema prevalence in high-income countries is almost equal to 0.5%, is almost equal to 1.5 million adults in the U.S., with an incidence of is almost equal to 0.1% per year among cancer survivors. A limb volume difference greater than or equal to 10%, or greater than or equal to 200 milliliters absolute increase between affected and unaffected limbs defines diagnostic threshold per ISL 2023 criteria. Manual lymphatic drainage, MLD, performed 5 times/week for 45 minutes each session yields a mean volume reduction of 28%, 95% CI 22 to 34% after 4 weeks. Multilayer compression bandaging applying 30 to 40 mm of mercury at the ankle and 20 to 30 mm of mercury at the calf reduces interstitial fluid pressure by is almost equal to 15% compared with no compression, p less than 0.001. Therapeutic exercise, 30 minutes of low-impact aerobic activity 5 days per week, improves lymphatic flow by is almost equal to 12%, Doppler lymphangiography, and increases calf muscle pump efficiency by 18%, p equals 0.004. Topical emollient used twice daily decreases cellulitis incidence from 12% to 5% over 12 months, RR equals 0.42. Prophylactic oral penicillin V 250 mg twice daily for patients with recurrent cellulitis reduces infection rate by 68%, NNT equals 4. Low frequency, 1 Hz, pneumatic compression devices applied 30 minutes twice daily achieve a mean limb volume reduction of 6% after 2 weeks, p equals 0.02. Quality of life, LIMCL, scores improve by a mean of 1.8 points, SD equals 0.9, after 8 weeks of CDT, p less than 0.001. The International Society of Lymphology, ISL, recommends initiating CDT within 3 months of lymphedema onset to achieve optimal long-term outcomes. Hazard ratio for progression equals 0.62. Compression garment where greater than or equal to 12 hours per day for greater than or equal to 6 months maintains greater than or equal to 80% of initial volume reduction, p equals 0.003. In patients with stage 2 lower extremity lymphedema, combined CDT and intermittent pneumatic compression, IPC, reduces cellulitis episodes by 45% versus CDT alone, p equals 0.01. Overview and epidemiology. Lymphedema is defined as a chronic, progressive accumulation of protein-rich interstitial fluid due to impaired lymphatic drainage, leading to swelling, fibrosis, and functional limitation. The International Classification of Diseases, 10th revision, ICD-10, code for primary lymphedema is R60.0, whereas secondary lymphedema is coded R60.1. Globally, the prevalence of lymphedema is estimated at 0.7%, is almost equal to 55 million people, with regional variation, 0.9% in North America, 0.6% in Europe, and 0.5% in Asia, World Health Organization 2022. In the United States, secondary lymphedema accounts for 85% of cases, most commonly following breast cancer surgery, is almost equal to 20% of mastectomy patients, and pelvic malignancy treatment, is almost equal to 15% of gynecologic cancer survivors. Age distribution shows a bimodal peak, 30 to 45 years, primary congenital forms, and 55 to 70 years, secondary forms. Female sex is overrepresented, female, male equals 1.8:1, due to higher breast cancer-related incidence. Pathophysiology. Lymphedema results from a cascade of molecular and cellular events initiated by lymphatic transport failure. Primary lymphedema frequently involves germline mutations in VEGFR3, FLT4, SOX18, or CCBE1, leading to hypoplastic or aplastic lymphatic vessels. Secondary lymphedema commonly follows surgical disruption of afferent lymphatics, radiation-induced endothelial apoptosis, or chronic inflammation. At the cellular level, impaired lymphatic shear stress reduces PROX1-mediated transcription of lymphatic endothelial markers, decreasing LYVE1 and podoplanin expression by is almost equal to 40%, P less than 0.01. The resulting stagnation of protein-rich fluid triggers a chronic inflammatory milieu characterized by elevated TNF-alpha, median 12 pg/ml versus 4 pg/ml in controls, IL-6, median 18 pg/ml versus 6 pg/ml, and TGF-beta1, median 22 nanograms per milliliter versus 9 nanograms per milliliter. These cytokines activate fibroblasts, promoting collagen deposition and adipogenesis. Adipose tissue volume can increase by is almost equal to 25% within 12 months of onset, MRI quantification. Clinical presentation. The classic presentation of lymphedema is a painless, non-pitting swelling of a limb that progresses insidiously. In a multicenter cohort of 2,400 patients, ISL 2023 registry, the prevalence of specific symptoms was atypical presentations occur in 12% of elderly patients, greater than 70 years, who may report only stiffness without obvious swelling, and in 8% of diabetics where ulceration can mask underlying edema. Immunocompromised patients, e.g., post-transplant, may present with rapid limb expansion, greater than 15% in 2 weeks, and systemic signs of infection. Key points: limb heaviness, 92%. Tightness, 78%. Reduced range of motion, 64%. Recurrent cellulitis, 31%, average 2.1 episodes/year. Diagnosis. A stepwise algorithm is recommended by the International Society of Lymphology, ISL, 2023 Guideline. 1. History and physical, document onset, prior surgeries, radiation, infection, and comorbidities. 2. Limb volume measurement, use pyrometry or water displacement, calculate volume difference. Diagnostic threshold, greater than or equal to 10% increase or greater than or equal to 200 milliliters absolute difference. 3. Imaging, key points, lymphoscintigraphy, 99 mTc nanocolloid, is the gold standard, sensitivity is almost equal to 92%, specificity is almost equal to 85%. Indocyanine green, ICG, fluorescence imaging provides real-time lymphatic flow, diagnostic yield is almost equal to 88% in stage 2 disease. MRI with T2-weighted fat-suppressed sequences identifies fibrosis, sensitivity is almost equal to 80% for chronic changes. Venous insufficiency, positive duplex ultrasound, edema improves with limb elevation. Management and treatment. Patients presenting with acute cellulitis or lymphangitis require immediate empiric antibiotics, e.g., for cefazolin 2-GQ8H, and limb elevation greater than or equal to 30 degrees. Vital signs, HR, BP, SpO2, are monitored every 4 hours, serum creatinine and liver enzymes are checked daily. If systemic sepsis is suspected, lactate greater than or equal to 2 millimoles per liter, ICU admission is indicated. Although CDT is the cornerstone, pharmacologic agents address complications. Key points: penicillin V, assess for hypersensitivity, liver enzymes monthly. Furosemide, monitor serum potassium, target 3.5 to 5.0 millimoles per liter, and creatinine, increase greater than 30% triggers dose reduction. Frequency, 5 times/week, 45 minutes each, for the intensive phase, first 4 weeks. Technique, Vater method, light stroking at 0.5 centimeters per second. References. 1. Donahue PMC et al. Advances in the Prevention and Treatment of Breast Cancer-Related Lymphedema. Breast Cancer Research and Treatment. 2023, 200, 11-14. PMID, 3710358, https://pubmed.ncbi.nlm.nih.gov/3710358. DOI 10.1007/S10549-023-06947-7. 2. Sanger J.B. et al. Current Concepts in the Management of Primary Lymphedema. Medicina, Kaunas, Lithuania. 2023, 59, 5. PMID 372411126, https://pubmed.ncbi.nlm.nih.gov/372411126. DOI 10.3390/Medicina 590508994. 3. Cheville al. et al. Cancer-Related Lymphedema. BMJ, Clinical Research Edition. 2025, 390. PMID 410657270, https://pubmed.ncbi.nlm.nih.gov/410657270. DOI 10.1136/BMJ 2024-081351. 4. Gilchrist et al. Effectiveness of Complete Decongestive Therapy for Upper Extremity Breast Cancer-Related Lymphedema, a review of systematic reviews. Medical Oncology, Northwood, London, England. 2024, 41, 11-297. PMID 3943838, https://pubmed.ncbi.nlm.nih.gov/3943838. DOI 10.1007/S12032-024-02421-6. 5. Zupina A. et al. Predictors of the efficacy of lymphedema decongestive therapy. Medicina, Kaunas, Lithuania. 2025, 61, 2. PMID 40005348, https://pubmed.ncbi.nlm.nih.gov/40005348. DOI 10.3390/Medicina 61020231. 6. Rajaram R. et al. The Management of Head and Neck Lymphedema, a 2025 systematic review. Head and Neck. 2025, 47, 102897-2910. PMID 4075739, https://pubmed.ncbi.nlm.nih.gov/4075739. DOI 10.1002/head.28265. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.